Thanks for connecting to this virtual poster presentation and discussion with a recent AMCP Foundation Best Poster awardee. Next slide, please. The AMCP Foundation Best Poster Competition is hosted at the AMCP meetings each year, and we want to thank RTS Solutions for their generous support of the competition. Next slide, please. I'll be your moderator today, Jeff Heater, and I'm the AMCP Foundation Joint Research Committee member. And as we go to the next slide, I'd like to tell you a little bit more about JRC. And the Joint Research Committee, our committee objective is really to promote and encourage the creation and dissemination of relevant but also credible research and initiatives that advance patient care in managed care pharmacy, with also improving the healthcare for all. And we do that through three committee initiatives. The first one, to develop and update research agenda that identifies and also prioritizes critical evidentiary gaps in the literature within managed care pharmacy. The second is to then disseminate that research agenda to evidence generators, funding bodies, as well as others that advocate for the undertaking of research initiatives that address these evidentiary gaps in the clinical literature. And then finally, cultivate student and practitioner interest within research. So as we go to the next slide, we do this through the managed care pharmacy research agenda, and it's really focused on four main pillars. The first one is a focus on real-world evidence to inform managed care pharmacy decision-making. The second one is focused on value-based models within managed care pharmacy and how do they address the overall total cost of care. The third pillar is the impact of benefit design and or utilization management strategies on patient outcomes. And finally, the impact of direct patient care services that are provided by managed care pharmacy and what are their impacts on patient outcomes. So I'm really excited and have the privilege of introducing everyone to Minal Walvekar, who got the Best Graduate Poster awardee in the most recent AMCP meeting. Minal, it's a pleasure to meet you and to have you join us today. I'll go ahead and give you the floor.
Thank you so much, Jeff. Hi, my name is Minal, and I'm going to be discussing my poster, Comparison of Change in Cardiac Injury Marker in Glucagon-like Peptide 1 Receptor Agonists, SGLT2 inhibitors, and DPP4 inhibitor users in a real-world database. GLP-1 RAs, SGLT2 inhibitors, and DPP4 inhibitors are three different classes of drugs approved to treat type 2 diabetes, and this year semaglutide became the first GLP-1 RA approved to treat cardiovascular disease. SGLT2s have been approved to treat CVD and do really well in clinical trials, but as of now, DPP4s have no known improvements or any effects on cardiovascular outcomes. Type 2 diabetes is associated with an elevated risk of CVD, which is also linked with an elevated levels of lactate dehydrogenase, or LDH, which is an enzyme in the body that increases due to any type of cardiac injury or any type of tissue injury or inflammation. The primary objectives with this analysis was to compare how LDH changes between these three classes of diabetes drugs from baseline to the end of study, and also observe how the proportion of individuals with an elevated LDH changes as well. This was a retrospective analysis of California patients in the UC Health Data Warehouse, and we used ICD-10 codes and OHDSI codes to find all of the comorbidities and patient information. We compared the baseline versus end of study lactate dehydrogenase measurements, where baseline is defined as 1 month prior to their first ever drug use, and end of study is defined between 12 to 15 months after their first ever drug use. Every individual included in this study must be a first-time user of their drug class, and there must be no overlapping use at all during this study period. Every individual must have diabetes or obesity at baseline to be included, and everyone was required to have a minimum of 4 fills within the year to be included in this study. And we intentionally kept the adherence low because this is more reflective of how people would use these drugs in a real world population. It's very different than how you would see people use these drugs in a clinical trial. For our analyses, we used a paired t-test to compare the baseline versus end of study LDH to see if there was a statistically significant difference. And we also used a clinic or a linear regression using DPP-4 as a comparator to GLP-1 RAs and SGLT2 inhibitors to see if there was a significant difference. All analyses was conducted using SQL and R in Databricks. We could see on the left side, this is the table 1 of all people in each drug class. Each drug class has about 50 to 70 users. And on the right side, we could see the distribution of LDH from baseline versus the end of study. On the bottom, we could see that the values represents the LDH levels from 0 to 500. And if you see the red dotted line, this is the point that indicates an elevated LDH, which is 280 units per liter. Anything to the right side of this is considered elevated. You could see that each drug class has 2 different colors. The color represents whether it is a baseline measurement or distribution or the end of study distribution. And each individual will have 2 measures, which is their baseline versus end of study, which is also clear by the color. So we can see right off the bat that there is a clear difference in the baseline versus end of study distribution for SGLT2s. We could see at baseline, it is much wider and a larger proportion of individuals have a measurement that falls in the elevated range, but we could see a clear left shift at the end of study where a lot larger proportion of people are in the normal range. We could also see a clear difference in the medians. We do see a slight improvement for GLP-1 users. We see that there are slightly more people in the normal range at the end of study, but we don't see any noticeable difference for DPP-4 users. Here we could see the change of LDH in the 3 different drug classes. So this is the delta, and we could see that that SGLT2 has the largest mean decrease. If you look at the units, 0 is considered no change, so no improvements or no worsening of the condition. Anything that is a negative value means that the LDH decreased, which is good for the patient. And anything that's in the positive range, we could see that that is a elevation of LDH, which is something to be a little more concerned about. So once again, SGLT2 does have the largest mean decrease of almost about 40 units per liter. And we do see somewhat of a change for GLP-1 users as well, with a mean decrease of almost 20, but we don't see anything noticeable for DPP-4 users. When doing a paired t-test to see if there was a statistically significant change from baseline to end of study, we do see that SGLT2s and GLP-1 RAs do have a statistically significant difference, but we do not notice that for DPP-4 users. Doing a linear regression using DPP-4 as a comparator, SGLT2 does significantly better than DPP-4, but GLP-1 RAs does not do statistically significantly better than DPP-4s. Here we could see the proportion of individuals with an elevated LDH at baseline versus end of study. And we could see right off the bat that SGLT2 actually begins the study with the most amount of users with the elevated LDH and ends the study with actually the least amount of users with an elevated LDH. We do see some improvements for some users in the GLP-1 RA class of drugs, but we do not notice any difference for the DPP-4 users in this study. In all, we observed that SGLT2s and GLP-1 RAs were linked to a decrease in LDH, which could symbolize improvements in cardiovascular outcomes. With this analysis, I would suggest more research to be done for GLP-1 RAs and SGLT2s in their improvements in the cardiovascular space. I think this would be very beneficial for a majority of users who have diabetes and cardiovascular disease. I also want to acknowledge and thank my mentors, Dr. Watanabe and Michael Strand. They have been amazing to work with, and I've learned so much from them. And yeah, thank you. That was my presentation for today.
Well, thank you very much, Minal, for presenting that for us today, and great research, especially on a very timely topic, but also a topic that I know has a lot of research going on as well, and just another opportunity for us to see kind of how that is impacted in some of the information, especially with the study that you conducted. So, great job. So, as you kind of think about your research, and as we flip back a few slides on what our four research or the pillars were of the research agenda, where does your study fit within those four pillars?
I believe my study falls in the real world evidence category because I'm using a real world data set. This is the California All UC System Medical Centers data set of their patient information. And I also feel like my study design is a little bit different than how things would be in a clinical trial because, as I mentioned previously, I intentionally kept the adherence a little bit low because in the real world, like not everyone uses these drugs as prescribed. So I felt like we would get a larger range of like how this is actually used. So I think that's what makes it different from a clinical trial, and this is what makes it a little more real world.
Great. Well, thank you very much. So, if you don't mind, I have a couple more questions for you. And as you kind of think back at the research topic that you did, the research you conducted, there's a lot of topics, there's a lot of things, and a lot of areas of research that are going on. Why'd you focus on this particular research?
This topic was really interesting to me because I personally do have a lot of people in my life who are affected by diabetes and cardiovascular health. And not only that, but I think it's very important to do high impact research, something that can reach a lot of people and like benefit society as a whole. And I felt like in both angles, this topic kind of encompassed what I was looking to do with my skills as a data scientist and a researcher.
Great. So I know anytime we undertake research or anytime whether you get started, you see the everything through the process, things usually don't go as planned. Things come up, there's maybe on a good trajectory and then something happens. You gotta have to rethink some things, or maybe your research just went really great from the very beginning, which is awesome too. But if you think back, what are some of the things that you learned through this process and the process that you did with the research that you conducted?
I think doing actual real world research was very different than what I was used to in my classes because there was actually a lot of missing data, which was difficult to work with. Such as like units were missing, so sometimes I couldn't use the measurements. I think that was definitely the biggest hurdle I faced. Also, I guess in terms of like people not using stuff like they would in a clinical trial also makes it difficult to, if I wanted to have stricter criteria to do that. But that also makes it kind of fun because then you get to think a little bit harder and like find out how to get through these challenges. And I think that makes you a better researcher in the end.
Yeah, you bet. It's a great attitude to have as you go through research because sometimes, like I mentioned, it doesn't always go as planned. So, and you find things as you go. So that's great. So, one last question, if you don't mind. There's a number of people that are either thinking about research, they're either in kind of similar path that you're on, or those that are still in pharmacy school, or those that are still in school looking to graduate, or maybe they've been out of school for a while and are looking for a change or looking to do and conduct some research. What advice would you give others that are getting into research, maybe for the first time?
I think my biggest advice is to be inquisitive and just reach out to as many people as possible because for me personally, that opened every single door that has led me to my career this far. And I think sometimes, like, I think people are fearful that they feel like, oh, I have to know exactly what I want to do and I need to come up with a plan before I ask or reach out to someone. You can literally just say, oh, I don't know anything about this. I want to learn more. And people love that. And I think people love the attitude that you just want to learn more. So I think, yeah, my number one advice for anyone who wants to get into research or any field in general, like just ask anyone you think like is doing something really cool, just ask them a bunch of questions.
Thanks, Minal, and thanks for joining us today. It was great to learn more from you about your research that you conducted, as well as getting to know more about you as well. So again, thanks for joining us today. And I also want to thank you for listening. And for more information on the AMCP Foundation Best Poster Competition, the Joint Research Committee, and poster presentation resources, please visit the AMCP Foundation website. And some of those links are shown here on the slide in front of you today. Finally, a new AMCP collaborate community is now live. The managed care research community is designed to facilitate the exchange of ideas and information and also encourage in-depth discussions related to managed care research. So join today and engage in innovative and thought-provoking research discussions. Finally, I want to thank Artia Solutions for their generous support of the Best Poster competition. That concludes our program for today. Thanks for joining and have a great day.